Hi, my name is Laura. I'm one of the staff educators. Today we are going to go over TR bands. These are the transradial compression devices that are applied in the cath lab, usually after a cardiac cath. Also in this video, we will be going over the important equipment to have at the bedside, information that you should get from your cath lab nurse about your patient regarding your TR band, some of the monitoring that you should do while the patient's under your care, as well as how we're going to remove the band. And we're going to touch upon lightly just some of the complications that can happen. So let's get right into it. Let's start by going over some of the equipment that you're going to need at the bedside. You should have a Dynamat with pulse oximetry capabilities in the room. You should have a caution sign that simply states post-TR band and which extremity is affected, that there should be no blood pressure or tourniquets on that arm for 24 hours. With that said, you should also have the date and time so staff can prepare when to DC this precaution. So that should be clearly written on the signage as well, and it should be posted above the patient's head on the wall behind the bed so that people can see. We should also have some sterile 2x2s or 4x4s in the room, whatever your preference. A little bottle of sterile normal saline or sterile water. And finally, some sterile gloves and or regular gloves with your choice of a transparent dressing. Typically what we have on hand here is the Tegaderm, which I like to use, the smaller version and not the large. Okay, so report from the cath lab should consist of a few important details, most important being what time that TR band was applied and the volume of air that they used to achieve hemostasis. That should be written on the TR band, but you want to make sure that you have that information just in case. Should also include the extremity that they used, right or left, radial access site. Any complications that they may have encountered during the procedure, if there's any hematoma present or bleeding. Also, the TR inflator syringe should accompany the patient in a biohazard bag labeled with the patient's identification sticker. We can post that up above the head of the bed as well, so that we have access to that because it is dedicated to that patient's TR band. I like to keep mine taped to the wall so that everyone has access to it. Also, if it hasn't already been done, we need to document this in Epic under the LDA flow sheets. Let's move on to monitoring. When you receive your patient, keeping that extremity elevated on a couple of pillows higher than the elbow is ideal. We need to assess CSM, which is color, sensation, and movement of that extremity. Make sure capillary refill is appropriate, less than 2 seconds. Make sure the hand is warm and not cold or blue or excessively swollen. Distal to that site, a really great idea in practice is to put the pulse oximeter on either the affected thumb and or index finger, and this helps to reassure that the hand is perfusing. Vital signs should be done Q15 minutes times 4, then Q30 times 2, and then every hour times 4, and then revert back to what your unit policy is. If the patient has had an acute STEMI, vital signs are a little different, and I would encourage you to resource your Lippincott and elucid procedures. If a hematoma does develop, apply pressure and call the doctor stat. As far as activity goes with this patient, if their vital signs are stable and there are no complications, no bleeding, no hematoma, they can ambulate as long as the doctor has written this level of activity. Hi, everybody. Welcome back. This is the section that we are going to go over the actual removal of our TR band. We have our patient under our care. We did receive our inflator syringe in our biohazard bag with the patient's label on there, which I have previously suggested to keep at the patient's head of the bed next to your caution sign, just so that people can be safe as far as not doing blood pressures or using a tourniquet on that affected arm. Okay, so our 2 to 4 hours are up from the time that we have indicated from our actual TR band. Usually when you receive your patient on the band, you will notice that the cath lab RN has put a date and time on the outside of this clear device. This is the information that's vital. That's how it's going to govern how you're going to remove the volume of air moving forward. And more importantly, the time that we need to get this done in. So as you see here, I have a 1 p.m. on here. So my patient was not on Integralin or any of those GB2 inhibitors. So we're going to go ahead and start to remove the air 2 to 3 hours in. So I'm going to say I'm going to avoid change of shift since this was inflated at 1 p.m. So let's do 4 p.m. And just a quick word. These are see-through so that we can visualize the site. And I just want to make sure that you can actually see that there's a green dot here right underneath my thumb. And there's a hard plastic that helps protect the site. I will use my handy hand here to show you also without glare. There should be this little green dot here with a little bit of red underneath. A little bit of bleeding is okay. That's to be expected. It's just as long as no hematomas or active bleeding is noted, dripping, that kind of thing. So yes, we're looking good. There's only one air port on these devices. The pillow inside that's inflated that causes the compression can hold up to a full syringe of air, which this dedicated syringe holds 25 mLs. Here at Mass General Brigham, we like to keep it at a max of 18 mLs of air. So hopefully you'll never see a TR band with anything over 18 mLs of air. Usually we like to keep it between 8 mLs and 12 mLs of air. So my patient has 10 mLs of air written on their TR band. So what I'm going to do quite safely here is make sure my inflator syringe is empty. And I'm going to hold the syringe because sometimes when you connect these, the air inside the pillow will push back and we don't want it to deflate too quickly and cause bleeding. So I'm going to connect here, keeping my fingers on here so that this syringe doesn't back off. I'm going to pull out just the 2 mLs of air. Watching the site, there's no active bleeding. That's great. Patient doesn't have any complaints of pain. Nothing beyond the elbow. There's no obvious swelling, numbness. We still have a good pulse ox reading on our patient's index finger and or thumb on the affected side. 15 minutes goes by, nothing's happening. Life is good. We are going to now remove half of the volume that's in there. So if we started with 10 mLs, we took out 2, that leaves us with 8 mLs currently in the pillow inside the band. I am going to take out 4, as you can see, and I'm looking at the site, no active bleeding, and I'm going to stop at the 4 mLs. I'm going to wait another 15 minutes. Looks good, looks good. Fast forward. At that point, I'm going to remove all the air, which is the residual 4 mLs. Okay, I'm going to watch. Nothing has happened. Fast forward 15 minutes. We're going to take off our band. We try to keep this as clean and sterile as a procedure as possible. For this application, I'm just going to put on these gloves. Again, the idea is that we are always visualizing the site should any complications occur, which we will go over in the next slide. So it's at this point where we're slowly going to, I like to keep my thumb on the area, the insertion site itself, and just slowly take off the Velcro. Once this is free, I'm going to just gently roll the TR band up towards the fingers until we are off, constantly looking at the insertion site, and it's looking really good. So it's at this point where I take my sterile 2x2s, or you can use a 4x4. You can use sterile saline or sterile water. Pour it on here, have it all ready. And you're just going to gently dab, get off any excess dried blood. Be careful not to dislodge any clots. It's nice and dry. We don't fan here. Give it a second. It's at this point where we're going to put on a nice, clear, sterile dressing that we can see through. I have got a Tegaderm because they are just easy to use. You could use a large one. I like the smaller ones because when you go to take this off, why have to disrupt anything that you don't necessarily need to. So whether you put it on lengthwise or widthwise, again, putting pressure in the center, just like you would an IV, moving out around to have that dressing nice and secure. I'm going to just take this off. Here we go. And now we have a beautiful site that we can monitor if there's any bleeding or hematoma development. If you were to see, or if that were to happen, you would apply immediate pressure and call the MD stat. Okay, so this patient should not lift anything heavy for 3 days. And the only other thing that I should have mentioned was that to even start this process, we have to make sure that that systolic blood pressure is less than 160. Just with all hypertension, it tends to increase your chances of bleeding. So lucky for us, his blood pressure was 120/70, so that's great. Let's troubleshoot some of the complications that can occur in the following slide. Some of the complications that you can look for with your patient can be bleeding and hematoma. This is complicated by a history of hypertension, platelet inhibitors, and or thrombolytics. So if this should occur, immediately apply pressure for 15 minutes. If that's not effective, call the doctor stat. If this hematoma is occurring with the band still on, we are going to stop the removal process, add 1 to 2 mLs of air until the bleeding stops. It's not necessary to reinflate the pillow completely because sometimes just a few mLs of air will stop that, and it's better than filling it up completely. If this is ineffective, we can consider applying a second TR band to stop the bleeding. This would be done in the cath lab. After you remove the TR band and a hematoma develops, this is a complication that would require a manual pressure and to call the MD stat. And a good practice is to do vital signs, also oximetry, and check that CSM of that affected extremity. Kind of the worst case situation that can develop with hematomas on a TR band patient post-op is compartment syndrome. And this happens when a hematoma is present and it exerts pressure on the nerve and tissue, causing some ischemia. This usually requires a surgical evacuation of that vascular area that was affected. That's all we have on TR bands today. Please don't hesitate to reach out to us and check your Lippincott and Elucive resources. Thanks again. Bye.